haven't finished online check-in, please scan the QR code and complete it. Thank you. Ladies and gentlemen, welcome back to 2022 Asia International Conference of Aesthetic Surgery and Medicine and TAASM annual meeting. The comment session of today's agenda is facial cosmetic surgery. Our moderator for the first half of this session is Dr. Serena Rajbandari from Nepal. Dr. Serena Rajbandari is a consultant of Grand International Hospital and fellow of Tri-Service General Hospital, National Defense Medical Center. Dr. Serena Rajbandari, you may have the floor.
Thank you so much. I hope all of you can hear me. So a very hearty welcome back to the 2022 TAASM International Conference after the break. I hope you guys had a lovely coffee session. I'm Dr. Serena from Nepal, and our upcoming session is that of facial cosmetic surgery with esteemed surgeons. Our first presenter is Dr. Shan Juen Lin. She'll be talking about high-fold correction in revisional double eyelid surgery. Dr. Lin has done her retinal and blepharoplasty fellowship from National Taiwan University Hospital and has been working there as an attending physician since 2015. So, Dr. Lin, I would like to request you to go ahead with your presentation. Thank you.
Hi everyone, my name is Lin Shenjun, and today I'm going to talk about the topic of high fold correction in revisional double eyelid surgery. I'm an eyelid plastic surgeon in Eastern Geolo Clinic and an attending physician in Universal Eye Center in Taipei, and an adjunct attending physician of National Taiwan University Hospital. This is the basic anatomy of upper eyelid. The tissue related to today's topic are framed. The blue ones are levator, palpable levator, aponeurosis, and molar muscle. And this is muscles used to open the eyes. The green one is orbicularis ocular muscle. OM is used to close the eyes. The yellow ones, septum, preaponeurotic fat, and the retroorbicularis oculi fat, ROOF, roof, are tissues works on preventing adhesions. The common reasons of unattractive high crease include the first one is skin, and like improper design of skin or too much skin removal. The second one is fat, too much fat removal or unawareness of the pre-existing sunken eye. The third is levator aponeurosis, like inadvertent injury adhesion or awareness of the pre-existing ptosis. Before surgery, we need to do some assessment and evaluations. The first one is orbital fat, which is very important because enough orbital fat can prevent adhesion in revision surgery. There is orbital fat in the upper, lower, and left and right sides of the eye socket around the eyeball. Although there are different paths, the pressure should be the same. We can push the lower eyelid to see the vibration of the upper eyelid to judge whether there is enough residual orbital fat. The second is to see if the scar is depressed or even. The third is to assess skin tension above and below double eyelid line. If the skin is tight, shows that there is not enough skin. We can perform a surgery without any skin excision. If the skin below the double eyelid line maybe is very tight, the skin color is dark from poor blood circulation, and maybe there is ectropion at the same time. It is predictable that once we excise the skin, the crease will become narrower than expected. The fourth is that lack of thalamus need to be checked before operation. The common reason of lack of thalamus include too much levator muscle resection or too much skin excision in previous surgery. Orbicularis oculi muscle was damaged due to excision in a double eyelid surgery, or OOM was detached from narthocancus, is in a medial epicantoplasty surgery, or too much levator placation. Once lack of thalamus has been found preoperatively, if the reason is irreversible, it is very likely lack of thalamus will also happen after new operation. But if the reason is the last one, levator placation, it is reversible and maybe lack of thalamus can improve after surgery. The fifth is that we need to check very carefully to find out the main reason why last surgeries failed. This is the most important part. The eye opening muscle includes levator muscle, levator aponeurosis, and muller muscle. It's like a hand pulling the edge of eyelids to open your eyes. If there is a part where levator aponeurosis and skin attach, open eyes will wrinkle the skin inward, resulting in double eyelid folds. If we want to narrow the double eyelid fold, make another adhesion just below the original line is not work. When there are two respective adhesions up and down, the eye opening muscles still tends to pull the upper ones as it opens the eyes. Therefore, if we want to create a lower double eyelid fold, we must first completely remove the upper adhesion and totally wipe out the old one. If there is excess skin, we can excise the old high fold and creating a new lower one. But if there is no skin to excise, we can use the wild dual plane dissection to completely release the high crease. On the newly designed lower fold line, an incision it was made through the skin and the orbicularis oculi muscle. As the dissection reached the bottom of the septum, which may be collapsed and fused, the first dissection was made in a cephalic direction under the orbicularis oculi muscle, but above the orbital septum. The dissection released the anterior portion of the prior fold scar, and dissection proceeded 7 to 8 millimeter farther cephalic. Anterior to the retroorbicular oculi fat, the second posterior dissection started at the caudal orbital septum and raised a plane between the preaponeurotic fat and the levator aponeurosis. Thus, this dual plane dissection fully separated the prior upper fold incision from the prior levator aponeurosis attachment. Okay, if there is obvious adhesion at the subcutaneous level, you can consider dissection under the subcutaneous and above the OM to release the adhesion. There shows two cases that need to dissect this plan. In the left case, she received laser therapy for the lasma. After laser therapy, there was adhesion over the lesion that caused double eyelid lines not smooth. In the right case, she received multiple surgeries which made obvious superficial scars. In these two cases, because of the lack of skin, all scars were not fully excised. And the lysis of underlying adhesion can make the original scar less obvious and do not interrupt new crease. There are two major difficulties made from the last surgery. First is the adhesions. Now we know we can use wild dual plane dissection to solve it. The second is the tissue removed by previous surgery include skin, OM. Too much OM removal will lead to lagophthalmos or a notch on double eyelid line, and roof orbital fat or too much levator muscle resection. The removed tissue increases the difficulties and unpredictabilities of the second surgery. So, what's the problem from it? The common problems is in the reduced surgery. The first is crease shape. For the eyelid that is not being operated on, we can use the probe to shape the double eyelid and then use this line as the wound to perform the surgery. But when there is already a relatively high double eyelid line, we cannot use the probe to shape a lower one. So the design of the crease sometimes based on experience and have to be modified during surgery. The second is that the upper and lower flap of skin tension might be different. If both the upper and lower skin are tight, no skin excision will be better. But if the lower flap is tight, only the lower flap is tight, the wound should not be too much lower than the old one. The third is that we should find the levator sheath carefully, especially in cases had received levator plication or going to do it without skin excision. The fourth is to release all the adhesions over all the planes mentioned above. We can check out tractions with fingers, especially when we need to change the outward crease to inward crease. The fifth is not enough orbital fat. Fat is the key to prevent readhesion. We will talk about later. The last one is depressed scar. The most common reason of depressed scar is from the splitted OM. Some physicians remove the OM under the wound or closing the wound without OM under it. In that way, there will be a gap of OM beneath the wound. There are options like autologous fascia transplantation or close the splitted OM with 7O bicryl. Of course, procedures to prevent readhesion is very important to prevent the old depressed scar to form a double eyelid fold again. In the lower pictures, the space I dissected is between OM and roof. There is a wide gap between OM. White is the color from the subcutaneous tissue. The middle picture shows a gap too, and the right one is after I close it with multiple sutures by 7O vicryl. Okay, in this case, I dissected the space between the subcutaneous and OM. There shows a gap near the nasal canthus, and I already closed it with 3 stitches. Okay, there shows the fourth stitch, the suture. I used the 7O vicryl and suture the gap. In that way, the knot is buried into the OM. Okay, in addition to the lysing of adhesion, it is equally important to prevent re-adhesion. First, there need to be a smooth gliding zone over levator sheath. Fat is a good buffer between levator and OM. It is the key to establish the gliding zone. As long as the levator muscle has the strength to contract, there can be enough movement of posterior lamina to prevent re-adhesion. Correct alignment of tissue layers can prevent adhesions as well. Orbital fat is very important for second operation. Of course, in the first surgery, we should better keep the septum intact. If there was orbital fat tissues prolapse, we can tighten the orbital septum by electrocoagulation or suture by 7-vicryl, instead trim the fat. In the revision surgery, we would better maintain as much as possible the previously trimmed orbital fat. If you really need to remove some fat, make sure there is enough orbital fat in the nasal side. What are the sources of fat? Of course, the best and the most natural one is the original orbital fat. If there was not enough orbital fat, we can consider some autologous fat clumps or micro-autologous fat grafts from around the belly button or thighs. The first one is orbital fat, which can be pulled down as a buffer between OM and levator sheath. It can be free or be fixed on tassm or near the wound margin or close the skin with the orbital fat. All can have the effect of preventing adhesion. If there is not enough orbital fat, the most commonly used sources of fat are fat clumps and microautologous fat. Both of them can be used on the surface of levator sheath and into the septum. If the amount of fat is too low or the length of the orbital fat and the septum is too short, the distal ends of the levator aponeurosis can be sutured back to the retracted orbital septums, acting as an extension of septum. In this way, a space can be created for fat transplant and provide a smooth surface inside to be a perfect gliding zone. If there was no intact septum, that means we cannot put fat into a bag, and the amount of fat placed on the aponeurosis is limited because of the instability. So we have to inject microautologous fat into soft tissue. I do this procedure with muffed gun invented by Professor Lin Caiming. We can divide the eyelid into 3 areas. Zone 1 is the subbrow area. Zone 2 is the area from the lower margin of zone 1 to the 1 to 2 millimeter above the eyelid crease with eye opened. And zone 3 is the dynamic area of the double eyelid. We can transplant fat into zone 1 in several layers, deeper, middle, and superficial layers. In zone 2, only a superficial layer is transplanted. In zone 3, no fat transplantation was performed. Sometimes we are going to show some cases, and please do not record the picture or video that. Thank you. Sometimes patients who complain that the double eyelid fold is too high. In fact, ptosis and thickness of the lower lip might be the real reason of dissatisfaction. Lowering the crease is the way how the patient expressed. The most important thing is to uncover the real reason of ptosis. Of course, too high folding will exert the weight burden of the levator muscle. Releasing the high fold itself can improve the levator function. Other common reason of ptosis is a secondary blepharoplasty include adhesions, which restricted the movement of the levator muscle, or the pre-existing original poor levator function before the first surgery. Ask the patient for the eye picture without any operation to figure out the real levator muscle function is one way. The left one is the undercorrected congenital ptosis. The right one is the injured levator muscle from last surgery. How to accurately evaluate the levator muscle function during surgery? The most important thing is not to be affected by the anesthetic and swelling effect. A precise neuroblock is the key of success, which can reduce the amount of local anesthesia near the lid margin and prevent direct anesthetic effect on levator muscle, which lead to a fake ptosis during surgery, or direct anesthetic effect on OM will make the eye open wider and temporary lagophthalmos during operation. An appropriate advancement of levator muscle not only correct ptosis, it prevents readhesion as well, because the levator muscle contracts and slides enough to avoid adhesion on the levator sheath. Besides, we should carefully dissect it to preserve intact levator sheaths if previous surgery have done levator placation. This picture shows a hole on levator sheath from previous levator placation over the temporal side. And if the previous surgery conducted molar resection, the adhesion will be stronger than levator resection, and we should carefully preserve molar muscle. There are lots of methods of ptosis correction. Mostly, I perform levator muscle resection, mularectomy, conjoined fascial sheath suspension in my revision surgery. And I always made 3 fixation points for levator muscle resection. The picture in left lower corner shows how I measure the amount of levator advancement. I set the junction of the levator muscle and levator aponeurosis to be the 0 point. Then count the length of the aponeurosis is left in the front. I rarely cut the muscle itself unless it is a patient with congenital type ptosis. Otherwise, mostly no need to cut the muscle to correct the usual ptosis. So the 0 point is the junction of muscle and aponeurosis, and the number I showed later means the millimeter of aponeurosis I left in the 3 fixation points. There is one other important thing before operation is the education for patient that because the adhesions from previous surgery and the tissue removed by previous doctor, symmetry is not guaranteed and only achieve major target without making minor adjustments, and more than one operation might be needed. If neuroblock anesthesia is failed, there are clues help to predict symmetry. Check lagophthalmos every time before surgery. It helps to determine if OM is over anesthetized during operation. If there was no lagophthalmos before surgery and both eyes closed at the same speed, but during operation, especially after one movement, you add more anesthesia. One eye become more lagophthalmos without any more levator advancement. That indicates that OM is anesthetized. The eye will open bigger than it really is. So don't afraid to keep the eye wide open and do not add more levator advancement to the other eye. Since there is no way to have the eye symmetry during operation if one eye has been over anesthetized, we can have the patient open their eyes frequently, especially after each major movement, to judge the effect from the movement. Beware of overcorrection of eyes and with non-congenital ptosis. If no matter how the levator muscle is shortened, the effect is not obvious. The levator might be over anesthetized and there is no need to strengthen the muscle that much. Okay, do not bleed heavily in levator muscle. That will influence on the movement of levator muscle. Okay, I'm going to show some case for you, and so please don't take any pictures and videos for if there is patient's picture. Thank you very much. Okay, this is a case of unexpected adhesion from last surgery. She has received non-incisional double eyelid for both eyes, incisional double eyelid and levator muscle resection for both eyes, and a non-incisional double eyelid for left eye. She wants to correct multiple creases, one natural crease. I have done both levator aponeurosis and molar resection for her left eye. The fixation points for aponeurosis is 0, 0, 2. 0 is the nasal side, 2 is the temporal side, and only do incisional double eyelid for the right eye. This is a case which injured the levator in previous incisional double eyelid. She wants to correct the ptosis. Because there was skin excision for the right eye, of course we should do the same amount for the left eye. There was lots of skin excised for agent eyelid. Levator injury was found in the right eye, and the levator muscle was cut in the previous surgery. For symmetry, I did the same amount of levator muscle resection in the left eye. Orbital fat was poured and fixed to the crease margin for both eyes. This is the case of pre-existing ptosis without correction from last surgery. She have done multiple times for non-incisional double eyelid and incisional double eyelid without correction of ptosis. She wants to be symmetry. I have done incisional double eyelid for the right eye and levator muscle resection for the left eye. The 3 fixation point for aponeurosis was 2, 2.5, and 3. For the left eye, the 3 is the temporal side. There was skin excision for the left eye. This is the case with pre-existing ptosis. He has received upper incisional trichiasis correction for both eyes, lower trichiasis for left eye. He has the different vision of both eyes. Clearly, he only used right eye to watch. And there was lower lid retraction with minimal lagophthalmos after previous surgery. So we should do levator resection conservatively on left eye. I've done minimal levator resection with the fixation point to be all 3.5 in the right eye and 3.5 for the nasal side and 4 for the middle and lateral side for the left eye. But I do more molar muscle resection than levator aponeurosis resection to prevent lagophthalmos because molar muscle is an elastic tissue. Orbital fat was poured and fixed near crease margin for the left eye for prevent adhesion. Sometimes there was more than one surgery needed to revision. What is the timing of secondary operation with unfavorable result? In my experience, there was 2 timing. One is after removing stitches and before 2 weeks after operation. If different of margin to reflex distance, MRD, is more than 1.5 millimeter. The advantage of adjusting now is that the tissue is still movable just like during operation. We can barely change and resuture the stitches without tearing the tissues. But the disadvantage is that the tissue was still swelling and we cannot judge the symmetry precisely. Another timing for secondary operation is 3 to 6 months after operation. The advantage is that we can know the final appearance without swelling. The disadvantage is that this will be like a new reduced surgery. Here is the take-home message. We always maintain previous orbital fat, which is very important to prevent adhesion. Precise neural block anesthesia is the key to symmetry, while dual plane dissection is the basic step of high-fold correction. And we always lower the crease and patient's expectation at the same time. Thank you very much. This is my website with English version.
Thank you, Dr. Lin, for your wonderful presentation. Are there any questions from the on-site audience? Okay, good enough. Thank you, Dr. Lin, again. So if there aren't any questions, we shall move on to our next presenter, who is a very well-known surgeon from Australia, Dr. Tuan Pham. He will be presenting on Caucasian upper blepharoplasty and transblepharoplasty, browplasty, browpexy. Dr. Pham is a fellow of the Royal Australasian College of Surgery and the fellowship director of the IFFPSS approved fellowship in facial plastic and reconstructive surgery since 2012. He is also a senior advisor of the International Board for Certification in Facial Plastic and Reconstructive Surgery. So without further ado, Dr. Pham, I would like to request you to please start your topic of presentation. Thank you.
And slideshow. So, can anyone hear me? Hello? Should be right. Yeah, so my name is Tuan Pham. Thanks very much for invitation to this prestigious event. I'm in Perth in Western Australia, so that's my city. Perth there with the beaches and the state emblem. I'm in private practice predominantly, and there's no disclosure. So outlined of the talk is on definition, bit of anatomy, surgical technique on upper blepharoplasty, bit of infrabrow brazier suture, and the main topic would be lateral brow transblepharoplasty, either browpexy or browplasty. There's indication, contraindication, a few case selection, and there's advantage and limitation and discussion at the end. So definition, look, is the management of the eye upper lid is really managed upper lid plus the brow. So it's a brow-eye complex, they're part of each other. So the upper blepharoplasty alone is just basically the skin aspect and fat of the upper eyelid. Okay, so and the transblepharoplasty browplexy or browplasty is used in the same blepharoplasty incision to manage the lateral part of the eyebrow, either pexy, which is really stabilization, a bit elevation, or browplasty, just like a mini brow lift. And the brazier suture is just to help to maintain the infrabrow fullness and also create a nice supertarsal crease laterally. So there's upper blepharoplasty in this young lady, upper blepharoplasty plus on the left side browplasty to make it even because there's a little ptosis there. Or in her, she's got severe dermatocriplasis, but her brow is very lax. So by just doing upper eyelid, it may bring the brow down. So we're doing a browpexy just to maintain the brow, so we can resect the maximum amount of our eyelid skin. Anatomy, the last speaker went through, but we're dealing with the anterior lamina, basically skin, bit of muscle, and bit of fat in the upper blepharoplasty. And for the brow pexy, blepharoplasty is in this the septal area, so it's above the perioseptum, above the periosteum. So this layer here, go back, and so it's along above the arcus marginalis. We're dealing with this periostal lift of the brow pexy. And of course, is limited by immediately the suborbital nerve. Occasionally, I do a medial one, but we won't discuss today. So it's really lateral, the suborbital nerve, and to the temporal fossa. We mentioned this lateral brow. Okay, vessel again, and the layer is the layer of 4. So it's above the periosteum in the brow pexy, in the subgaleal plane. Again, this layer there under muscle above the periosteum. So assessment upper blepharoplasty is indication, some marking, and how I do it is skin, muscle, and fat, and brow. So indication is really for upper blepharoplasty is excess skin with a pseudo herniation over fat. Occasionally you can do the Asian blepharoplasty with creation double lid fold with extra skin resection. You can combine with toast repair, and also you can combine with a lateral brow stabilization or lift used in the same incision. Technique is everyone has to be individualized. Is that managing the skin, muscle, and fat, and how much you resect depends on severity and which component is affected. Conservative is better. So the option is skin only if there's just very thin and no muscle, no fat. Skin and muscle if it's excess, which is very common in Caucasian, also in my area, because there's a lot of sun damaged skin. There's inflation of skin and muscle, and you just cauterize the periorbita. Or if there's fat protrusion, mainly the middle and medial especially. And then later we'll discuss how I do the brow plasty or pexy. And of course, if there's lacrimal ptosis, then you can suit that up. And again, you can use a couple of techniques to reposition the roof fat, toast repair. So a young person, in Caucasian, is usually the superstar crease, vary between men and female, but I like around 7 mil, 6 to 8 mil is the standard, and depending on the person, depending on the height. So younger person, the incision is just medial, it's lateral, it's the left eye. It's really come out from the lateral canthus. But as you get older, more limited places laterally, you increase the length outward, and then more elderly further out, but never, ever to the over rim. And when you measure, there's an apparent supertarsal fold, but supertarsal fold can be influenced by ptosis, so you have to be careful. Even I try to the incision used is just below that. You can use the caliper to measure it. Again, in female, it's about 8, in men, it's just slightly shorter, but normally just a bit 1 mil below that crease. And then how much skin removed? Well, really how much brow skin you have to leave behind. So that's 6 8 mil. You want to leave from the infra brow to the lashes about 20 mil, minimum 18. And so you take the amount necessary to preserve those measurements. And everyone different. And then the medial canthus, there's a number of ways to manage some of the skin here. I prefer just come here and then just a little kick back that way rather than W-plasty. And then the lateral part taper depending on the severity of the ptosis of the dermatochalasis. So this is a little assessment. So you measure there, supertarsal crease, just mark it out. Then the patient open and close the eye, and then you pinch the skin. It's just enough for the lashes to turn up. Okay, and you measure it, you can there's probably 8 mil, there's 12 mil, there's 20 mil. So, and she's lower lid at the same time. So in her brow is good. So then the brow, again, the measurements, there's but I think about 7 mil, and lifting up here about 30 mil. So the amount of skin here, again, you pinch the skin on an upright position. I don't do anything on the line down because there's, everything is on upright position, where you assess the brow and everything else. And you can see, it's just more out here, so the more lateral extension, and this look more of a lateral upward, and so is this one. So allow the skin to remove and the scar to be high here rather than go too low. The technique, you can do this in local anesthetic many times, and for upper blepharoplasty alone, I think 80% are doing the local anyway. More, I use just a blade, mark the skin, take the skin off first, and then amount of muscle removed depending on how much you need. Usually a strip of muscle if it's a lot of muscle, and then you then access to the oval septum, and depend where the fat protrusion preoperatively you mark. Medial, you just make a little puncture or a little snip in the oval septum, palpate a little bit, and then fat will come out, and then you just remove that, and then cautery, same as the middle fat. And the rest of the preorbital, I just cauterize to give a bit of fibrosis on the preorbital, and then you suture it up. Okay, so then after that, one can do a brassiere, help enclosure, and it's fat removal, peripheral cautery, and suture it up. So this, again, if this case here with minimum, there's no muscle removal at all, you just make a little snip in the muscle and periorbital, and then palpate the fat and come out and just manage that accordingly. Clip it, cut, cauterize, and then suture the skin. So the skin closure, I favor 6 of protein running subticular, stick up here, stick up there, and we'll pull that in 5 to 7 days time. So this is a video of pretty simple, play music in the background. So it's a skin removal there, and it's just a bit of snip of muscle, depending on how bad it is. On this side, with brassiere suture, just suture the upper muscle, upper part, lower part, into the periosteum of the orbital rim. That gives it a sympathizer crease and its fullness to infra brow. That's fat removal, and it's a suture there. Go together. That's how I operate both together. And then this is the brassiere suture here. Okay. Upper muscle, go down to grab a lower muscle, and then suture into the infraorbital rim periosteum. Muscle there, and then infraorbital rim periosteum there. Just where the lateral fossa underneath there, of course. So when you close it, it just gives you a nice sympathizer crease, and also increases fullness here. And then subticular skin closure. And then subticular skin closure there. So pull that. So that's pre-op, immediate post-op. There you can see distance there is to maintain at least 20-22 in her, and she's got no eyebrows, so no need to do anything. So that's 2 months. A nice crease, open eye a bit more. That's brassiere suture. Give it a fullness here, which is nice and very give it a volume, and also deepen this sympathizer crease. I like it very much. This suture. Again, in another lady, 6 months, she's 30-something years old, and a 6 month, again, didn't do the brassiere, he doesn't need it, and her, she's happy there. So that's a simple upper blepharoplasty, maintain the sympathizer crease, and she's a year. you can use Botox, but for more permanent or laxity, you can use the drains blepharoplasty approach, same incision as blepharoplasty for lateral brow stabilization, plus or minus elevation, called a brow pixie, or a limited brow lift, brow plasty. Okay, and there's other way to do brow lift, obviously. And of course, mentioned is lateral to supraorbital neurovascular procedure. So it's limited, and it's the main indication is stabilization. I think they use most for to prevent the brow come down while you resect a lot of the excess skin, and when the patient have brow laxity. So this is a couple of examples here. So the patient have slightly low brow, a lot of skin here, and you take it out. Bit of brow stabilization. In her, you show it's high. It's high because she's moving her brow up because there's so much dermatocyclosis. All this increase up here. But in relaxed form, that's dropped down. So you might take amount of skin, stabilize the brow so that brow doesn't come down. Okay, and this lady here has got unilateral brow ptosis. It's about 3 to 5 mil there. And you just do with the left side alone to give it symmetry. So that's the area affected there. And all that is bilateral. So the technique, do the upper blepharoplasty first, then elevation of lateral brow is lateral occipital neurovascular bundle to the mid temporal fossa, and it's about, depend on the level you want, either 1 or 2 centimeters above the brow. The dissection plane is then suborbicularis, but supraorbital septum, so preseptal. And then you go up to the orbital rim, and then you enter the subgaleal space, okay? Because your arcus marginalis, which is a periosteum, is intact, and you elevate that, avascular plane almost. There's some little vessel you cauterize, but you stay always super periosteal. The section depends on how much high you like. And then fixation of the roof fat. So try to avoid the bicularis in your suture to the periosteum above. So that gives you a bit of brow lift. And I normally just use a 5 PDS. Taper really for 5 is best, and then 2 sutures laterally, and additionally the brassiere suture to give it even more effect. So this is the plan we talk about, the supra orbital. So this plane here, the supraseptal here above this plane. So in her supral nerve, you can mark out, and then I just mark a couple where the sutures are, and then that's it. Do the bleph first and do that part. So now the assessment is you elevate the brow where you want, and then you measure the amount of skin removal. Okay, so when you do this thing, so the sutures is there. So mattress, horizontal mattress sutures, periosteum to the roof fat, time 2, then a brassiere suture at the end. So that's just elevate, put the sutures through the roof. You can do the other way, roof first, or the periosteum first, tie it once, and then another one more laterally, and then the brassiere suture and close the skin. So, okay, on the other side, to the periosteal, to the roof, and skin. So this is a video here. So this is preorbital.
So between the muscle and the periosteum.
Okay, so that's this is subgaleal space in here. And use a centractor.
Above periosteum.
Okay, so that's the periosteum underneath there. This is all. You can sometimes do just cauterize. Okay. Then more laterally. The more vessel is more lateral than you get a little vessel there. So you're below the facial branch. Okay, so you're not injuring any branch of nerve at all, and that's the cavity of the. And then you put the suture to the periosteum first, higher.
Periosteum.
Sometimes need 1 or 2 go at it, so it's not all smooth selling. And on this side here, then come back, take a roof fat or fat inferiorly, and then put it fat there. And then you suture. You tie it.
Lateral bit.
So you tie it and the brow guard.
And you tie that up.
There you go. That's the first suture. And then another one.
Mm-hmm.
So there's a suture there. Then you do a more lateral. This is more tricky because you already got one. Sometimes you just do suture first, let it hang free, then tie both later. But I'm getting used to it. So again, infrabrow, soft tooth fat. Again, tie. Then at the end, you judge it. I did Brescia suture, as mentioned earlier. So that's superior orbicularis. Then grab the inferior orbicularis. That's just a lateral canvas here. And then suture that to the oral rim periosteum. Just likely, if it's too much, loosen it. Bit tender with some patience. Sorry about the music. Yep. Then you suture that in. There you go. That just gives a fullness here as well, and a stop, and it could give us a very nice supertarsal crease. So, what's the aim of this procedure? Is lateral brow stabilization. That's the main key. Is the brow pexy to stabilize, so to maintain it, so prevent further descent or ptosis of the lateral brow after your skin resection. So you optimize the amount of skin upper lid skin resection with it. Mild lateral brow elevation, so probably up to 5 mil, but not more than that, I think. Indication, so is dermatochalasis the upper lid plus brow laxity or brow ptosis mild moderate only, okay? And also very good for brow symmetry, mild symmetry adjustment. Contraindication is if severe brow ptosis, then I think this doesn't work. It's mild, and if it's severe medial brow ptosis, so you don't want a more lateralized elevation. If you have so severe medial, it look odd. So how you determine assessment is the key. So yes, brow is, and also the brow and mobility. So this is how I do it. Assessment, you grab the skin, that brow come down. So if you're going to take that skin off here, that brow come down. Later on, let's do a hooding. So this is here, use the finger or use a forceps. So a lot of skin, but this is very lax here. So you move it up and down, that brow come down very easily, okay? So if you take it off, our post-op will come down. That's lax skin. So in her, you want to stabilize or you want to elevate a little bit. So you mount, so fixation, and then you can calculate how much skin come off. In her, she's mild and moderate. She's a borderline doing an open brow, but she likes a small procedure, which I think we can get away with. So it's this very lax brow. Okay. So you just take that skin from there to there up to the thing, you'd be too much skin take off. Okay, because it's a lot of this is infrabrow skin. So you elevate the brow.
Very lax. And you just take this away only.
So that take it up there, see how much brow come.
Come down. So you stabilize it, then you can take this much skin and elevate it.
So
then
in her, there's asymmetry. There's the right side here is less here. Line them up, and you want to just increase this part. Okay. Asymmetry, and for that, you can see
higher this side.
the more this minus
This here is not very lax. It's very down out there, so there's no real movement of the laxity. But we can try to just the plexi or brow plastic to do that. So bring it up a bit there.
okay. So in this case, over there. So it's not for the brow pixie at all. Okay, it's severe, and you won't get enough elevation for that. So in her, I recommend a full brow management.
Come off. Or brow lift, and you take
severe.
Put it off. That's the best way. The skin can show here. That's the brow. The stabilization is just this part. Still not come down. Without it here,
yeah,
a lot of the skin.
A lot of skin. Just that. So brow elevation.
If you take all the skin away, it's too much.
Too much.
The brow will come down.
So what's the result? In her stabilization here, that's first week, bit of bruising, but they give it more fullness there. This patient's the unilateral brow on the left side now. So elevation, you see here, is more even. So that's afterward. 8 weeks post-op another patient. And again, give a nice crease, fullness of the lateral brow and the infra brow. So that's give youthful. And the Brazilian suture plus the brow, it gives you a nice sympathizer. In her, the same, she's very relaxed. She's trying to raise the eyebrow up, but once it's done, give you a more arched brow. Then more arched brow. So a bit of elevation in her. There's fullness here, become more elevated. Less time operating, it's just a quick recovery, effective for mild cases with minimum mobility, a bit of swelling, a bit of tenderness, and patients accept very well, I think, and avoid the standard brow lift. The limitation, look, is really, the main thing is to stabilize the brow. So there's minimum no change. There's 5 mil, I think, maximum to a lateral brow lift, but it is with suture and especially thin skin, and there's a bit puckering of the suture to the up. That will resolve usually, and if you include the muscle, a bit more. And of course, you manage the lateral brow only. There can be brow asymmetry if you don't put the suture symmetrically. There is a potential septal nerve injury if you go to medial, and the frontal branch, or if you go to superficial. So some result, you can either, this is a more moderate laxity, but it's improvement, okay? There has to improvement rather than do a full brow lift on her. And if you just do skin alone, I think the brow will come down. So thank you very much. Complication-wise, touch wood, mainly the bit of bruising, bit of swelling, but there's no real injury to any of those nerve or vessel that I can think of. So, questions?
Thank you, Dr. Pham. I'm sure everybody enjoyed that brilliant topic and gained a perspective on your surgical techniques. I might have missed it, but what suture material do you normally use for the bracciary suture in lateral brow elevation? And would you prefer localized or general? So material.
So the sutures, BioPDS taper. That's my main suture, because the taper got a round needle and doesn't tear through the periosteum or the skin. So the taper FibroPDS is coming there, and a 3/4 needle around. So it's very, very nice. I use for both, for brassiere and the suspension. The skin is just 6 protein. So I'm very simple kind of that point of view.
Okay, and do you prefer local?
And more, yeah, but majority, just for that, I'll do it on local. Generally only if the patient requests that they're just too anxious about it. It's not a pain problem, it's just anxiety that someone operate around the eye. I would say 80%, if that's alone, I just do it on local.
Okay, it seems like Dr. Kao has a question for you. So, Dr. Kao, would you like to ask your question?
Yes,
Hi, Steve.
Hey, how are you? Thank you, Dr. Tufan, for accepting our invitations. So I just a question about the lateral brow plexi. So would you do
Yes.
under local, right? Under local. How about
Majority case.
the longevity, the long-term result? How, because you know that we know that the brow position will changing after double eyelid surgery or brow lifting, because the brow position will balance after a while. So how can you anticipate
Sure.
the longevity of the brow plexi or lateral brow lifting? How about the longevity?
Look, initially they always improve, but I think after we're trying to follow them for 1 year. It's
About 1
very
year.
hard and to get them more back than that. But majority haven't come back to say, I have the same problem, because you do most of this with the upper blepharoplasty, which is the main indication anyway.
Yes.
So they're always very happy with it. The brow plexi and bioplasty is addition to allow you to resect maximum of the upper lid skin without the brow coming down. I haven't seen, the brow, lateral brow come down, with the operation. It's that doesn't come up, which is fine, which is, the plexi part. But the come down is very rare because you're moving a bit of stiffness up there. And of course, over time, all brow come down.
Yes.
But having an issue, they come back in a year to get it revised that way.
Mm-hmm.
It's really assessment. If severe, I'll recommend the other open brow first.
So are there any more questions from the audience? Okay, so thank you, Dr. Pham. It was a pleasure having you speak on the topic. So
Thank you.
So we shall move on to our next presentation, which is a pre-recording by Dr. Henry John Claraval from the Philippines. So he will be talking about his techniques on the cherubic forehead, scalp advancement, and forehead reduction surgery, how he does it. And Dr. Henry is an expert in reconstructive, functional, and revision rhinoplasty. And he's a fellow and vice president of the Philippine Academy of Facial Plastic and Reconstructive Surgery. So I'd like to request the technical team to start his presentation, please.
Hi, everyone. I would like to congratulate the organizing committee headed by Dr. Steve Cao, my friend, and also thank you for inviting me to talk. The title of my presentation is Cherubic Forehead, Forehead Reduction Procedure, Scalp Advancement Surgery, Bone Tunnel Technique, how I do it. So what is cherubic? Others will say cherubin or cherub. It is actually a theological character who's a member of the second order of angels. They have this distinct gift of knowledge, and they are often represented by a winged child or a winged head of a child. The face is always round, and the forehead is full and curved. They say that the cherubin is a symbol of innocence, sweetness, and love. Same is true with what you see with your kids. That's why I'm showing to you my daughter. She's Ashi. She's 3 years old. As you can see, her forehead is very round and curved compared to my forehead. There. As an adult, the size and shape of the forehead may tell something about our personality. It has been said that having a curved one is a symbol of vibrancy, positivity, and happiness. There. Another way of looking at the forehead is by facial proportions. To have good harmony, the face should have 5 equal parts vertically and 3 equal parts horizontally. The forehead, which is also part of the upper face, should be more or less equal to the height of the mid-face as well as the lower face. According to the study of Susan et al., the natural most common height of the forehead from the glabella to the hairline is around 58.3 plus minus 6.6 millimeter for women, and for men, it's around 61.4 plus minus 9.7 millimeters. It has been said that the normal height of the forehead should be at least 4 fingers breadth from the eyebrows to the hairline. That's why they call it forehead. Now, if you're going to look at Rihanna, as you can see with her, two fingers breadth in order for you to reach the hairline from the glabella. So for Rihanna, sometimes we called it six head. Having a high forehead is a symbol of masculinity, seriousness, and having the signs of aging. So what are the causes of high forehead? The number one cause is, of course, genetic, followed by aging process, previous history of surgery like the bicoronal surgery, and of course, trauma. So if you want to guess what will be the appearance of your forehead when you grow old, you just have to look at your parents, your father or your mother. There are many options to lower the hairline. You have the non-surgical and the surgical. Under non-surgical, you have the makeup. You can apply makeup to your scalp and even the face. You can do some hairstyle modifications, or you can do some tattooing, or nowadays, it's really very popular, is what you call microblading, either microblading the forehead or even the eyebrows. Now, for the surgical, you have two options as well. You have hair transplant and the scalp advancement surgery. So what are the advantages of doing scalp advancement? As you can see, you will have a shorter surgical time. The hairline will be very predictable since you're just advancing your natural hairline to the new position lower than the forehead. Then there will be no donor site, and the shape of the hairline is very natural. The disadvantage is that the surgery can be very bloody, and it is dependent on the scalp laxity. It is not really indicated for some hair pattern baldness. There will be numbness of the scalp for around 1 to 3 months, and there's always a possibility of wound dehiscence. That's why we need to do some anchoring devices such as endotyne. And for my presentation today, I will be doing bone tunnel technique. Now, for the hair transplant, the advantage is really best for some male pattern baldness. You can actually design or customize the hairline. You can have it like a heart shape or M shape. Now, the disadvantage is that you need a longer surgical time. Sometimes it's half day, or some other times it can be whole day. Survival of the transplanted hair is always a factor. Not all hairs will survive. The donor site will also depend on the surgeon. There are two ways to harvest the hair, either the strip method or the FUE method. You also need special machines like the FUE devices, and sometimes you need ARTAS. You need extensive training while doing these machines. You need a lot of manpower to finish the surgery. You need the harvester, and also you need the planter. This will make your surgical time shorter than the usual. Now let's discuss the boundary of the forehead. As you can see, superiorly, it is bounded by your hairline, inferiorly by your eyebrows and your glabella, and laterally by your temporal fusion line. In order for you to identify the temporal fusion line, is you can actually ask your patient to clench or to bite. Then if you will feel for a muscle movement, that means that you're in the temple region. But if you do not feel any muscle movement, that means you're in the forehead regions. Now for the anatomy, the forehead, same as the scalp, has 5 layers starting from the outside to the inside. You will have your skin, your connective tissue or subcute. You will have the aponeurosis or the galea aponeurotica. You will have the loose areolar or the gliding plane. Then you will have the periosteum. An important layer to consider is always the third layer, which is the aponeurosis or the galea aponeurotica. So in here, you will find your muscle as well as your vessels and also your nerves. So you should not be able to dissect at this layer so that the surgery will not be very bloody. There. That's the galea aponeurotica. The blood supply of the forehead comes from the branches of the ophthalmic artery, namely the supraorbital and the supratrochlear. It will start very deep at the level of the supraorbital rim, becoming more superficial superiorly to supply the frontalis muscle at the level of the aponeurosis. The nerve will follow the course of the blood vessel. Doing nerve block, a landmark to follow is you will have to drop a line at the medial limbus, and then you will intersect it with the edge of the supraorbital rim. The intersection will be the point of origin of your supraorbital artery or even the supraorbital nerve. In here, you can inject local anesthesia so that you will be able to numb the forehead on top of that nerve. Scalp laxity should always be assessed prior to surgery. It can be done by using the pinch test. So you can have a very loose scalp, you can have a moderately loose, average, or moderately tight and severely tight skin laxity. It is important for us to choose wisely when we are doing surgery, because higher wound tension will lead to difficulty in closing the wound and eventually wound dehiscence. You will have widening of the scar. You will have the possibility of wound ischemia and necrosis, as well as telogen effluvium of the surrounding skin or hair loss. Others are advocating the use of laxometer. It is actually an objective way of assessing scalp laxity. Now I would like to present to you my patient. So the height of the forehead, starting from the hairline to the glabella, is 6.5 cm, and the scalp laxity is average. My plan is to do this. I will first design my incision, then I will do my excision, then I will do my subgaleal dissection, followed by bone tunnel to anchor my scalp, and then I will now advance my scalp to meet the edges of the lower flap. Then I will suture them together. Now for the incision design, we will be doing a W tricuspid incision at the hairline around 1 to 2 hair follicles from the skin. So the superior limit is the hair, and the lower limit will be around 1.5 to 1.8 from the hairline. Then the lateral limit is the temporal fusion line. So I would like to present how I do it. So this is cherubic forehead by Henry John Claraval. First is I will do the supraorbital nerve block with a mixture of epinephrine and lidocaine. As you can see here, I'm injecting the area of the supraorbital, then followed by the supratrochlear nerve to block the supply of the forehead. I will be injecting around 1 cc per point. Then I will do injections also to the skin excision area so that I will be able to infiltrate and hydrodissect my flap. Now I'm doing here the tricuspid incision along the hairline. Tricuspid meaning to say I'm in between the follicles. Now I'm already doing the incision at the lower skin. I do not use cautery to excise my skin because that will damage the hair follicles. What I'm doing here is I'm creating a window for my bone tunnel later on. I'm incising actually the periosteum. Now I'm doing the bone tunnel technique using the 2.0 drill bit. I will just penetrate the outer table until I reach the diplo. Then I will also drill the other side of my tunnel so that they will meet in the midline. Now I will try my suturing using the needle, or sometimes I will just use the suture to pass underneath the bone tunnel. When my suture is in place, I will now do my scalp advancement, followed by anchoring of the scalp to the bone tunnel. This will make my scalp stable and it will not move because of the anchoring. By the way, I'm using here a non-absorbable suture around 30 nylon. It's enough. You can also use 40 nylon. Then I will cut it. And then later on, I will be proceeding to close the layer from the inside to out. Before I do that, I will try also to dissect the lower flap on the subgalea. And I will now do my flap approximation. Now I'm suturing the muscle first, followed by the dermis, and the outside incision. Now, what do you mean by trichophytic incision? Trichophytic incision is a kind of incision wherein you bevel your blade or your knife so that the incision will be in between the follicles. Usually, nowadays, actually, I'm using the blade 11 so that I will be able to be very parallel to the scalp around 30 degrees so that I will be able to really preserve my follicles. Now I'm playing the video on how I do it. As you can see, the blade 11 is actually almost same is at the same level with my scalp around 30 degrees so that I will be able to bevel it properly. I will also do that kind of incision for the lower margin of my excision. As you can see, if you will do that way of incision, you will be able to have a better looking scar after your surgery. This one. Now, let me try to explain to you how I do my bone tunnel fixation. As you can see, if this is the outside world, this is the cortical bone or the outer table. This is your brain already or the inner table. And this is the diplo or the middle of the skull. As you can see, if you drill the outer table, you will feel for a give. Then at that point, you need to stop because you're already in the diplo. Now, after that, you need also to drill the other side of the tunnel so that they will meet in the middle. Please do not do two gives when you're drilling. Because as you can see, if you have two gives, mean to say you're already penetrating the cortical bone or the inner table. This is the fourth day post-op. As you can see here, there is good coaptation of wound and there is no wound tension. As you can see there, the forehead size has been shortened after the forehead reduction or the scalp advancement. This is another before and after. As you can see, there's a significant difference between the before and after when you use your scalp advancement surgery. This is another before and after. This is already around, I think, 6 months after the surgery. So let me just also emphasize how I do my galeal window when I'm doing the bone tunnel technique. Nowadays, I do not make a big incision in my periosteum. I will just do what you call Galeal window. I will not cut the entire periosteum. If I will do this, preserving the periosteum as much as possible will lessen the tension when you're doing scalp advancement. So now I'm doing here the bone tunnel. And another modification is I found out that it's better to do a vertical oriented bone tunnel rather than having a horizontally oriented bone tunnel because it's much more ergonomic when you're advancing the scalp. During forehead reductions, since the forehead is already open, for example, in this case, the patient underwent forehead reduction together with the excision of the osteoma. It is now very easy to excise the osteoma using the drill when your forehead is open already, like this. So you can flatten the osteoma very easily because it's really exposed. Now, for the complications, you have the possibility of swelling, bruising, of course, numbness around 1 to 3 months. Dehiscence is always a problem when you're having a high tension. That's why you have to be very conservative with your excision. You have to always check skin or scalp laxity. And there's always be a possibility of scarring if you will not do the trichophytic incision. Hair loss can be a problem, especially after 1 to 2 weeks after surgery. That's why you need to explain it that sometimes there will be some hair loss. But if you're sure that you did not actually hurt the follicles, all the hair will grow to the skull. And you have to be very careful with your bone tunnel technique because you will have the possibility of intracranial complication if you're not very careful and you accidentally penetrated the inner table. Now, for the take-home message, forehead advancement surgery or scalp advancement surgery is a great option for facial harmony. It is important to do the trichophytic incision when you're incising. Tensionless closure is very important, and you should be able to select your patient wisely. So thank you very much for this talk and hope to see you soon in person.
Okay, I hope all of you enjoyed the presentation by Dr. Henry. He's not available for question and answers, so we shall move on to our final presenter before the break, Dr. In-Sang Kim from Korea. He will be presenting on key points of endoscopic brow lift in Asians. Dr. Kim is a board member of the Korean Academy of Facial Plastic Surgery and the Korean Society of Aesthetic Surgery. Dr. Kim, I would like to request you to share your screen and please start your presentation. Thank you.
Thank you for your kind presentation, introduction. I want to talk about key points of the endoscopic brow lift. Sorry. Sorry. Do slideshow. Okay. Right. Strange. Okay. Sorry. I'm In-Sang Kim from Dr. B and Young Aesthetic Clinic. Okay, brow lift is a procedure to reposition the brow with amelioration of forehead and glabellar lines. Usually the eyebrow is lower medially and higher laterally with a variable arch. So there have been some attempts to define the ideal shape of the brow, but it's not easy. And by the review of Gunter and others, the aesthetic ideal cannot be generalized. and it must be assessed in relation to sex, ethnicity, and overall facial proportions. So preferred shape of the brow is influenced by culture. So some doctors talk about some ratio, golden ratio in the brow, but I don't believe in the theory that much. Usually these days, Korean young ladies prefer this straight shape and fuller shape of the brow. So very straight and full shape of the brow. This is preferred by Korean women, Korean young ladies. It's difficult from Western counterparts. The Western ladies like this arched shape of the brow is different from Asian cultures. So I think the arched shape is much better in Western Caucasian faces. Straight is a little bit awkward, but you see. So arched shape is better for Caucasian women, but not the straight shape. But it's different from Asian cultures. So the brow lifting can make the face much younger, much brighter, much rejuvenated. So you can see pre-op and post-op after the endoscopic brow lift. There's no scar at all, you can see. So there are many brow lift procedures, coronal and forehead plasty, direct brow lift. But endoscopic forehead lift has advantages like less complication, clear visualization, short recovery time. And this is the direct brow, subbrow excision. You can see direct brow lift. You can see the very unsightly scar along the brow. And there's no improvement medially. That's the problem also. This is the corona brow lift. It's very strong. The effect is very strong. So you can see very nice results after the corona brow lift. But the problem is it's most reliable procedure, but problem is the scar, alopecia, and permanent cell sensor loss. These are the problems. So endoscopic brow lift was introduced in early 1990s, and it was created with enthusiasm and hope, less scar, no less complication, faster recovery time. So its basic concept is the functional dynamic brow lift by frontalis muscle when the depressed muscles are modified or weakened. So open approach is just rely on soft tissue traction. That's the difference. So if we weaken the brow depressors, then the brow elevators will move the brow upward, and the new brow position is set at the higher position. So endoscopic brow lift has advantages like negligible scar, patient acceptance is more, and fine muscle modification on the magnified view, and physiologic change of muscle tone, especially medial brow and nasal root. For the medial side, effect is much better than other procedures. But endoscopic brow lift is often blamed for a high recurrence rate, in some study up to 9%, and there are some concerns for longevity. But in my experience, this lady had an endoscopic brow lift 10 years ago. So this was 3 months after the surgery. This is 10 years later after endoscopic brow lift. You can see the brow is still elevated. And nice brow elevation. You can see this is immediate post-op. This is 10 years after. Immediate post-op. This is 10 years after. So she came to me this time for the facelift. So I did facelift at this time. So this is the result of the facelift. So you can see the longevity of the endoscopic brow lift. For the successful outcome of the endoscopic brow lift, you have to release the ligamentous attachments around the orbital ring. So superior temporal septum and the lateral orbital thickening and orbital ligaments. So you have to release these dense attachments around the orbital ring. That's the essence of the endoscopic brow lift. So this is the superior temporal septum, and you have to release the orbital ligament. Orbital ligament is the very dense, thick ligamentous attachments at the superolateral corner of the orbital ring. And this is the lateral orbital thickening. This is different from the lateral canthal tendon. So you have to release this lateral orbital thickening during the endoscopic brow lift. And another important thing is you have to release the ligamentous attachments along the superior orbital ring and the nasal root and also superior orbital ring, and saving the supraorbital and supratrochlear nerve bundles. So you have to preserve these nerve bundles and you have to release the periosteal attachments along the supraorbital ring. And the release of the medial brow is very important, especially for Asians. The Caucasians prefer arched shape of the brow, and they don't like the medial brow elevation. But I think medial brow elevation is very important in Asian brow lift. And so you have to modify the brow depressor muscles as much as possible. So there are four depressors: procerus corrugators, medial slip of auricularis oculi muscle, and depressor supercilii. So you can see the transverse head and the oblique head of the corrugator superior superciliary muscle and medial slip of the orbicularis oculi muscle. And if you resect the corrugator muscle, then you can see the depressor superciliary muscle and procerus muscle medially. And you have to preserve the nerve bundles, and the nerve bundles are intermingled with the corrugator muscles. So you have to resect the brow depressor muscles, preserving the nerve bundles as much as possible. And you can use the endoscopic forceps, or you can use the bipolar forceps. I prefer bipolar forceps these days more. So now I'm dissecting the maybe medial slip of the orbicularis oculi muscle now. So you can see the subcutaneous fat now. And left side of the maybe corrugator muscle I'm dissecting. So I use forceps and I use the now. So you have to preserve the bundles as much as possible. Oh, it's not moving forward. It's strange. Okay. So now you can see the left side of the supraorbital nerve and supratrochlear nerve. Remaining muscles and resecting between the supraorbital and supratrochlear muscles, nerves. And now you can see the left side of the nerve bundles. supraorbital, supratrochlear, and now right side of the nerve bundle, supratrochlear and supraorbital nerves, and all the muscle fibers were weakened. Okay, so you can see nice elevation of the brow, and especially the medial brow is elevated, pretty nice. So you can see much younger and much brighter appearance after the endoscopic brow lift. And in this case also, nice elevation, you can see, especially the medial brow, you can see elevated. If you elevate the brow, especially medially, then you can improve the fullness of the nasal root and the frown lines also. So medial brow is very important part of the brow lift. You can see much brighter, younger appearance, and medial brow elevation is very important for the Asian patients. So you can rejuvenate the upper face. And some surgeons talk about say that positive canthal tilt is increase the brow endoscopic brow lift will increase the positive canthal tilt, so it will be harmful in some patients. I agree, but in some patients it's true, but generally in most patients it's not is beneficial actually, even for the Asian patients. Increasing the positive canthal tilt is beneficial in most patients. So you can see the increased positive canthal tilt and much brighter and open and younger appearance. And you can see also increased positive canthal tilt is beneficial in Asian patients. Also, you can see increased canthal tilt is beneficial even in Asian patients. And about the double eyelid, combining the brow lift and double eyelid surgery. Double eyelid surgery is the most common aesthetic procedure in East Asian countries. And upper light should be evaluated with contiguity with the eyebrows and the forehead. And usually heavy brow tissue is related to the thick skin and bulky subcutaneous fat. So for the elderly patients with redundant eyelid skin, you have to consider the brow lift first before or in combination with the brow blepharoplasty. But in younger patients also with heavy eyelids, the heavy soft tissue should be lifted first by brow lift or in combination with the double eyelid surgery. So then you can have much better results. So ideally, endoscopic brow lift proceeds first, and at least a month, and ideally 6 or more months later, double eyelid surgery is performed. And when the brow and infrabrow tissue is elevated, the eyelid skin is stretched thin, and supratalar creases will be much more natural and beautiful. So you can see pre-op and post-op. You can see that in the pre-op, we can see heavy infrabrow tissue. So after the endoscopic brow lift, you can see the release of the heavy infrabrow tissue, and now you can see that much brighter and open appearance, and the supratalar crease is much more beautiful after the endoscopic brow lift. And brow lift and rhinoplasty is a powerful combination, but there has been a relatively little attempts to integrate analysis of the nose and brows. And brow elevation with modification of the glabellar muscles will deepen the mesium, create concavity in the forehead to the nasal root, and elongate the overall nasal length, and also make the brow tip aesthetic line narrower and more defined. So you can see augmentation rhinoplasty and brow lift is performed in combination. You can see the brow tip aesthetic line is much more defined and much more beautiful, and you can see the nice profile with endoscopic brow lift and rhinoplasty together. And also in this case, you can see the heavy infrabrow tissue and low set brows. So and she wanted a revision rhinoplasty. So I did endoscopic brow lift and revision augmentation rhinoplasty together. Then you can see the much more brighter and much more better results with combination surgery of the endoscopic brow lift and rhinoplasty. Also, revision rhinoplasty was done with combination with the endoscopic brow lift. You can see much more brighter and much more beautiful profile after the combination surgery. And in this case, also very strong appearance preoperatively and very short distance between the brow and the eyelid, and is lifted. The brow is lifted, and you can see the much more brighter appearance, and you can see the nice brow aesthetic, brow tip aesthetic line after the endoscopic brow lift and rhinoplasty together, and you can see the nice profile with the combination surgery of the brow lift and rhinoplasty. Also, in this case, I did the brow lift and the rhinoplasty together. So much longer appearance of the nose, you can see. So the nose is much longer and much better. So, and another problem of the endoscopic brow lift will be in patients with thick, furrowed skin or high arched foreheads. So this is the weak point of the brow lift, the endoscopic brow lift. But then you can combine the open approach together with the endoscopic brow lift, and you can remove some skin, and you can do the endoscopic assisted brow lift together. So you make small brow lift together. So it can be called as a mini open brow, removing some skins. So in this case, you can see the thick skin with deep furrow of the forehead. So I wanted to remove some skin of the forehead. So I removed the skin, and I did endoscopy assisted forehead lift, and we can see the improvement of the forehead wrinkles, and you can see the much brighter appearance after the surgery, and the sky is negligible. And in this case, the forehead height is pretty high, so I removed some skin, doing forehead reduction and doing forehead lift together. So you can see much brighter appearance and reduction of the forehead, and also another case of forehead reduction. And you can see the decrease of the forehead height and the brighter appearance after the endoscopic assisted brow lift. Another patient with long forehead, so I did the forehead reduction with the endoscopic assisted brow lift together, and you can see the nice result. See, and in this patient, this male patient was complaining about the high forehead height. So I did forehead reduction, and he was planning to do the hair transplantation to the forehead. So this size is not a problem. So anyway, so I did the forehead reduction. You can see the great improvement of the forehead height. So you can combine the endoscopic brow lift and with the mini open brow together, and you can have more better results. Thank you very much. Thank you.
Yeah. Thank you, Dr. Kim, for the wonderful presentation. So does anyone from the audience or online participants have any questions they'd like to clear up?
Dr. Kim,
Mhm.
Can I ask you how often did you do the brow lift with the upper blepharoplasty simultaneously? How often?
I usually recommend always brow lift first. So I don't like concurrent surgery. Sometimes I do, but
You don't like concurrent surgery?
yes.
Okay.
It's always brow lift first, and some months later, maybe double eyelid surgery. I prefer this sequential surgeries.
But Taiwanese patients usually like to have one surgery to solve all the problem.
So, but I persuade them to have brow lift first.
How about Dr. Kim? Thank you for your wonderful lecture. So
Thank
how
you,
about
Bob.
you do, like in Taiwan, people love to have an endobrow lift combined with the suture upper blepharoplasty, because patients like to see the early results to open the upper crease. Yes. So sometimes we just combine, do a simple procedure, suture.
Yes, not a problem. Yes, right. Okay.
Thank you.
Okay, thank you.
Yes, Dr. Kao and Dr. Chen, they also do a lot of endoscopic brow lifts. So it must have been very interesting for them, your topic. So thank you, Dr. Kim, for your wonderful presentation.
Thank you very much.
Dr. Henry, welcome back. I think you were on a flight.
Hi, good morning. So right now I'm on the road. I'm on the way to Bangkok.
Okay, so
Sorry.
Dr. Claraval is available right now. Thank you, Dr. Kim. And Dr. Henry, your presentation on the cherubic forehead, scalp advancement, and forehead.
Yes.
Are there any questions for Dr. Henry? It's available right now. So from the on-site audience or from the online participants?
Henry.
Yes.
Yes. Nice to meet you.
I can hear you.
Yeah. Thank you. Your technique was wonderful. I love the result of the. It's kind of a reverse endoscope brow lifting. So did you do this kind of surgery on on the patient after endoscope brow lift? Because the some people after endoscope brow lift, their hairline will become higher. So would you combine with the endobrow lifting or after endobrow lifting?
Actually, if I'm going to do this to a patient, I always tell them that the intention is to actually to lower the scalp from below. We are lowering the hairline. We're not actually lifting the eyebrows. But I was really amazed with Dr. Insan Kim that he was able to present that actually we can combine the brow lifting together with the forehead reduction. In my case, I just do what you call hairline lowering, so I do not release the proceedings in the corrugator muscles. So maybe soon I would like to maybe try the technique of Dr. Insan Kim. Very wonderful. Can you hear me?
Yes. Thank you for your presentation. I saw that
yeah.
Excellent results. Very good result. Thank you.
Yeah. Okay. Thank you.
Since there aren't any more questions, thank you, Dr. Henry. I think you should rest now. You've had
I'm okay. I'm okay. Okay. Thank you very much for the invitation. Thank you.
Okay. So we shall now go into a break and continue with the session at 2:30 p.m. Taiwan time with Dr. Tim Chen. So thank you, Taiwan Academy of Aesthetic Surgery and Medicine, for having us. So happy learning and have a break.
Thank you, Dr. Serena Rajbandari, and all speakers' wonderful sharing. So it's time for a break now. Next session will be in 40 minutes later. Please be back on time, and thank you everyone for participating. So likewise, if you haven't finished the registration, so please scan the QR code on the line, and we'll see you later. Thank you, everyone.